in stroke rehab. Many therapists actually get certified in NDT. There's like levels of courses. They take months to complete, and they cost a lot of money. There's one coming up. It's not a certification course, but it's a due-date course coming up actually in April, and it's about $500 just to attend it, and I'm still not going to be certified once I'm done with it. But it will give me more knowledge. But therapists use it a lot. So a lot of the techniques used in NDT you will see later on in practice when you'll be out in the clinics. So this is just an example for those of you who had lab already. You can see the therapist, is helping the patient weight bear on the affected extremity while they're pushing up the stand, which is kind of part of the principles of what NDT is all about. We'll hear about it and talk about it in just a minute. So the history, it's a BOBAC treatment approach. There were a couple. They developed it in England in 1940. The husband was a physician. The wife was a PT. Okay, and she actually treated a lot of patients who had a stroke and also children with CP where they thought that they're not going to see any functional improvements with these people. And she managed to make some gains with them and develop this theory of neurodevelopmental treatment. It drew from the hierarchical model of motor control, okay? It observed abnormal movement in stroke patients, and based on that they developed their theory. They believed that their treatment would change spasticity and restore normal movement. Okay, so the main goal of NDT really is to restore normal movement patterns and to normalize muscle tone.
Can you repeat that one more time?
Yes. It's right here. That's okay. I will say it about 1,000 more times in this lecture. So it's, I said the main goal of NDT is to restore normal movement patterns and normalize muscle tone. Okay, everything you do is designed in order to normalize muscle tone, restore normal movement patterns in the affected side of the body. How you put your hands on your patients, how you design the room, what activities you do, all is with the focus of making sure that they are, that you're addressing the tone, addressing normal movement patterns. So some of the principles of NDT, okay, like I said, number one is normalize muscle tone. We say that a lot. Number two, you want to inhibit primitive reflexes. So sometimes after a neurological insult, you will see resurgence of primitive reflexes. Okay, we want to inhibit those, unless we use them therapeutically, which we'll talk about in PNF a little bit. What are some of the reflexes, the primitive reflexes you guys know? You learned them in 506.
Palmar grass.
Okay, grasp reflex. It's not this. It's this. It's actually not. It's the opposite direction. This way. What is that? On guard. Yeah, the fencing pose. What's it called? ATNR. Asymmetric tonic neck reflex. And then its brother? STNR, right? Symmetric tonic neck reflexes. Okay, so one of the tests we do when we have patients who've had a stroke, if they're very, very involved, we check, Babinski, we check a lot of responses. We want to see if there's any resurgence of primitive reflexes. Reflexes never disappear, okay? Reflexes get integrated into the system, and we learn to develop volitional movement over those reflexes. Okay, so we learn to move over the control of those reflexes. Sometimes as a result of an injury, you see reemergence of those reflexes. They can be used therapeutically, okay? But the goal is really you want to kind of inhibit those primitive reflexes. Obviously, it's not very functional that every time you turn your head, your body's going to go like this, right? Unless your goal is to facilitate elbow extension, you may want to use it, but functionally it's not going to be helpful. So you want to inhibit those. 3, you want to facilitate normal postural reactions. Facilitate normal postural reactions. Okay, normal postural reactions, normal postural control. After a patient had a stroke, which side do they want to hang out in? The involved side or the uninvolved side? Uninvolved. Yeah, they really like to be in the uninvolved side. Okay. Majority of the patients will be leaning towards the uninvolved side. About 10% of patients will lean into their affected side, and that is known as pusher syndrome. You will see that. And the reason it's called pusher syndrome is that the more you try to correct them to move away from their affected side, the more they push into that side. So you're standing on that affected side and they're leaning into you and you kind of push them other way and they're leaning into you more. And sometimes you actually need, this would be like the only time where as a therapist I will not be standing on their affected side. If I have a patient with a pusher syndrome, and even then it's questionable, but if they have a very severe pusher syndrome that only my body is stimulating them enough that they keep pushing to that side and they're going to fall, I will stand on the strong side and I would actually pull them from here towards the strong side because they will be otherwise falling in there. But that's only in about 10% of patients. It's very good to see when you see it. It's kind of a weird diagnosis, but majority of the patients, they like to be on their uninvolved side. What do we want to do in therapy?
Get them neutral alignment. Basically.
Yeah, get them in midline, get them in neutral alignment where they're weight bearing on their affected side, right? Proper posture. If they're sitting and they're just leaning on the one side, that affects posture, affects function, right? If they're standing and they're afraid of weight shifting into their affected side, they can't walk. It's hard to walk without putting weight on one side of your body, okay? So we want to approach them from the affected side. We want to stand on their affected side when we treat them. Oftentimes we use a mirror. You know, I have a mirror and I put tape in the middle of it and I tell the patient, keep your nose right where the tape is. Okay, and then we do activities and I have them find their midline. Maybe I weight bear and I have them come up and I want to see that they can find midline and not go all the way to the other side. Right, so mirror is really good, oftentimes to work with patients that have visual feedback. Key objectives of NDT: improve the quality of movement and help clients relearn normal movement patterns. It's achieved through various techniques, okay, and I'll talk about some of them in a bit, but first thing is we use handling technique, which I'll get to in a minute. So handling is one of them. We want to do weight bearing through the affected side. As much as we can, we encourage the patient to weight bear. Either when they're transferring, I want them to push on that affected side to push to stand. I'll transfer them towards their affected side. I'll make sure that they weight bear and engage in activity, even in standing maybe. I'll do something, anything where they can weight bear either on the upper extremity or the lower extremity. Bilateral use of upper extremities. Okay, so again, want to do bilateral integration. As much as we can, we have them use both sides of their bodies. We want to work on decrease fear and neglect. So oftentimes patients are really afraid to lean, to stand on that affected side because they're weak, their sensory input is wrong, right? They don't get appropriate feedback from the environment, from the floor, from the ground, and their sensory receptors, and they think they're going to fall, and they're terrified. They are terrified. So we want to help them decrease that fear by showing them that they can weight bear on that side, increase their awareness to that side, and they can still be safe, right? And of course, the more they attend to that side, the more you're addressing the issue of combating neglect, right? And then we want to avoid sensory input that will negatively impact muscle tone. We want to avoid sensory input that will negatively impact muscle tone. In the tone lab, I'm sure Leslie talked to you about how the environment sometimes can affect muscle tone, right? When you're stressed, you tend to be tight. When there's bright lights, a lot of noise, whatever it is that might affect your tone, even if you're not a person who has a neurological insult, right? So we have to think about it, maybe think about the environment, okay? The light, the sound, all those kind of things in order to inhibit if they have a lot of muscle tone. So techniques, like I said, handling, key points of control, guiding, inhibition, facilitation, RIPs, and placing response. We're going to talk about those in a minute. So handling. Let's say handling techniques. Handling techniques are, I'm trying to think how to define it, are just where we place our hands on the patient, where the therapist places their hand on the patient in order to improve the quality of movement. Improve the quality of movement. So where the therapist places their hands on the patient is designed to improve the quality of the patient's movements. Okay, it's designed to correct any malalignment. And it also may be designed to facilitate or inhibit tone. Okay, so handling is that general term for how I, as the therapist, place my hands on the patients. Those are handling techniques. That's me using my hands to, what I said, facilitate or inhibit tone, correct malalignment, and normalize movement patterns. And there are different types of handling techniques. So one of them is key points of control. And NDT is very specific about the places where you place your hands. Oftentimes you will see it around the pelvis, okay, in the back, shoulders, chest, a lot of that proximal, right? So we position them, that core, that postural control. I might work with the patient, they're sitting and they're in that posterior pelvic tilt on the edge of the bed, and I might come just in front of them, squat, and kind of pull them with my hands into that anterior pelvic tilt before we do any activity. All right, I might have one hand on their shoulder, one hand on their pelvis as I guide them through the transfers. Okay, so those are the key points of control. There's several areas that they like to place hands, usually around the pelvis, and the shoulders are the big ones that you will see. You see here she's supporting proper posture, okay? Most likely her other hand is around the chest area, and she's kind of facilitating upright posture with the patient. And the patient is weight bearing. Which side do you think is his affected side? Same guy that got off the chair before, the mat table.
Left.
Yeah, left. She's most likely sitting on his affected extremity, on his affected side. Okay, guiding techniques. Guidance is when the therapist places her own hands or his own hands on the patient's hands to guide them through normal movement patterns. So I want my patient to reach and grab something. I will put my hand on the patient and I will move their hand in those normal movement patterns. And the more they do it, hopefully, motor learning occurs and they develop normal movement patterns. Nothing becomes abnormal in how they move to reach to an object, okay? So we want to do it as much as possible to normalize the movement pattern through us using our hand on the patient's hand to guide the movement. Obviously, we're moving the involved side, okay? Not the unaffected side. So other than normalizing movement patterns, it also provides sensory input to that area, especially for sensory deficits. Once my hand is on them, I'm providing sensory input to that area. Another thing that it is very often our eyes tend to follow our hands. So if they're reaching towards something, they'll follow the hand. So now what happens? Visually, they're attending to that side of the body, so it addresses any kind of visual deficit. What else does it do if we're now attending to that side and there's all this sensory input? What else is it addressing? That oftentimes happens with patients, especially if they're left. Yeah, it addresses neglect or learned non-use, okay? It increases awareness to that side. All right, inhibitory techniques, all of those techniques discussed in the tone round. All right, in this case, what is the patient doing? The patient.
Weight bearing.
Weight bearing. Okay, remember, weight bearing most likely would be the correct answer from this point on. So, weight bearing, and you can see the key points of control, right? He has one arm on his shoulder, one distally maintaining that hand in extension. So I can't tell what tone this patient has, but he's either trying to facilitate tone or inhibit tone. Since we're talking about inhibition, I'll assume that he has high tone, right? And he's stretching him and he's trying to keep him in that prolonged stretch, right? With weight bearing to inhibit some of that tone. Okay, so inhibition techniques to normalize high tone, spastic muscles, and facilitation techniques. What's this therapist doing here? Tapping. Right, usually we tap if the patient has low tone or flaccidity. What other techniques we know for low tone for facilitation? What? I'm sorry.
Vibrators.
Yeah, vibrators. What else had I had? Okay, positioning, yep.
Weight bearing.
Weight bearing. It's like I was waiting for someone to say that. All yelling, weight bearing! Right, just so, Yeah, tapping, vibration, weight bearing, okay? Easting, there's all these things you can do to facilitate tone. RIPs, what are RIPs? Yes, reflex inhibiting patterns, okay? We position the patient in reflex inhibiting patterns in order to correct the pull of spastic muscles. Okay, correct the pull of spastic muscles. If they're here, okay, we want to position them here. Okay, and you can see that this little really lovely stick figure has extensor tone in the lower extremity, right? That extensor synergy. You know, so you want to put them maybe in a little bit more flexion, kind of combat that, but with the uppers especially, if they're here, as much as you can. Put them in the opposite direction of the pull of the spastic muscle. Okay, opposite of what we see is where we're going to position the patient. All right, NDT treatment goals. Use the facilitation, inhibition, and handling techniques to normalize muscle tone and improve postural symmetry. I told you I'm going to say that about 700 more times in this lecture. Inhibition techniques are used to, like we said, correct alignment, especially patients who have increased tone or spasticity. Okay, that correct alignment through those inhibition techniques, right? We lengthen the pull of those muscles, we position them in those reflex inhibiting patterns, all the stuff we talked about. We want to teach the patients methods of providing their own inhibitory techniques. What are some things you can teach patients how to inhibit their tone? Yeah.
Would it be like the unaffected side assisting the affected side for like upper extremity movement?
Yeah, so specifically to inhibit tone, we might teach them how to do their own self-range of motion using the strong hand to stretch the affected side, right? So I have to use it. We'll talk about assisting in a minute because they do use it, right? So teach the patient self-range of motion, prolonged stretch, proper positioning. Okay, if they have on a pillow or on a lap tray, I like the patient when they have the lap tray, I put the hand, I extend the fingers, right? And then I tell them, look at your hand, touch your hand. I make them rub the hand, provide that, you know, sensory input that it's right in front of them, they see it, combat that neglect. Facilitation techniques used to teach sensation of normal movement by moving the limbs in space with proper pattern of initiation and sequencing. Okay, so again, that handling, I might support movement of the limb by proximally holding the shoulder protracting, maybe through guiding, right? I want them to move the limb in space in those proper movement patterns. Another way I can do that is have the patient actually do it themselves, okay? That bilateral integration, I might have the patient hold their hand and move their hand functionally. So I want them to reach to the bottle with that affected side. I'll have them hold it, you know, and reach. Maybe they have a hard time holding. I might have them come here. Okay, engage in the activity. Hold the brush, hairbrush in one hand, the good hand hold it around it. Move them through those normal movement patterns. Engage it in the activity. Stimulation. Stimulate muscles directly, it's a typo, to contract isometrically or eccentrically. So if you have a patient who is stage 1 or 2 of Brunstrom, okay, not all of you had labs, so those of you had lab earlier today. What's stage 1 of Brunstrom? How much movement do they have? None. They're completely flaccid. And stage 2, what would they have? What lab today?
It was yesterday.
Yesterday, sorry. So you had a whole day to digest that. Stage 2, yes?
If they were 2, they would have a little bit more movement.
Yeah, they might start having a little bit, right? A little bit of movement, but they're not completely in that flexor synergy. So obviously, where are you going to work with them? Are you going to do against gravity or gravity eliminated?
Gravity eliminated.
Gravity eliminated. So maybe you'll start just with, you know, support and movement and gravity eliminated. Maybe just start with isometric. Okay, if they're flaccid, you need to facilitate. You're getting anything. You're going to start with some isometric contractions. Then you're going to work on eccentric. What's eccentric contraction?
Stretching.
Yes, lengthening contraction before you go to anything that's concentric. So I'll give you an example. when I work with patients who have had a stroke and I want to work on their triceps, because they tend to go here into that flexus energy, I want them to work on triceps, and they don't have a lot of tricep strength, and maybe they're actually quite flaccid. So I might first just work on holding the hand in isometric contraction. They're supine. They're laying supine, their arm is up, and I'll just have them hold the hand here, supine, with the elbow extended, and I tell them just hold it. Hold it extended. What type of contraction is that? Isometric. And I might help support here to keep it extended, and I just to try and hold it. Okay, isometric. Once I feel like I'm getting anything, the next thing I would tell them is, okay, lower your hand to your face slowly. Okay, if they have weak biceps as well, that hand's going to smash in their face unless they eccentrically contract their triceps. So I have them slowly work on this without hitting the arm in their face. Okay, and then I help them bring the hand up and I have them do it again. All right, and then once they get strength, being able to eccentrically contract, that's when I'll actively have them move against gravity, right? Because gravity is helping, right? So I want them to control that. Then I'll have them move against gravity into that concentric contraction, okay? So that's how you would work in terms of facilitating that tone eccentrically, concentrically, and isometrically. And then hold alignment and provide postural stability while practicing movement, okay? So you sit them up and you want them to reach maybe while they're sitting, okay? So they have to provide that postural stability, okay? Weight shifting is huge in NDT, being able to reach outside basic support and stay in that alignment. Also, maybe I might have them, just hold the position they're in and try to maintain that there while engaged in an activity, right? Anything like that, placing response. Okay, so further about facilitations, we want to re-educate normal patterns of movements, like I said before, through guiding, through bilateral integration. And we want to involve the affected extremity in all type of transitional movements and functional activities. Involve the affected upper extremity and lower extremity in all types of transitional movements and functional activities. What do I mean by transitional movements? When I talk about transitional movements.
Is that like actually transferring, like getting from a chair to a bed?
Yes. Transitional movements usually refer to transfers, bed mobility, rolling, supine to sit, sit to stand, transfer to the chair, transfer to the toilet. Okay, if you haven't had lab, you'll learn about how to position patients according to NDT, but everything we do is designed to incorporate and engage the affected side of the body. From how we position them in the bed to how we transfer them. Okay, so oftentimes when we work with patients, we transfer them towards their affected side. I'll have them sit, I'll have them reach back, I'll help support that side to push to stand, then I'll support the limb while they're taking a step. I might have to actually advance the leg, walk that knee from buckling, have them turn. What's happening when they're transferring towards the affected side? Weight bearing. Yeah, they're weight bearing on it, right? So we're weight bearing, we're increasing attention to that side, and then they sit. Okay, so everything we do, that is sometimes hard for families, for aides, for nurses. They have a hard time transferring patients to their affected side, especially if they don't want to weight bear and they don't have a lot of strength. So oftentimes I'll position the patient in the room that everything stimulates that side, right? I turn the TV, I turn the chair, that they have to attend to the door. It's like perfect NDT bedroom in the hospital. And then I have to tell the nurses when you get them back in bed, pull the chair out, turn it around, and transfer them towards their strong side because they just can't do it, okay? Ideally, you want to teach family members and you want to teach caregivers, maybe if it's long term, to work on that side to facilitate awareness of it. But just remember, even in transfers, we can't forget transfers. Transfers is part of function, so we have to continue facilitating movement towards that side. So basic treatment goals is going to be a little redundant. You've heard it, so if you cannot forget that we do weight bearing in the hemiplegic arm, okay, or leg. Okay, we want to use the involved side in ADLs. We want to weight bear on the affected side. Weight shifting and sitting and standing with controlled shift over the involved legs. So we want to do as much weight shifting as we can when they're standing. Often because they do avoid weight bearing and the left side is my affected side, I might put a little step stool under it and it's kind of forced weight bearing. Once it's there, it's almost like forced weight bearing. They tend to want to weight bear on it a little more. Scapular mobilizations to maintain scapulohumeral alignment and mobility. What position of the scapula do patients often get into after a stroke? Say I'm Tony. Yeah, they tend to be retracted, okay? When you're retracted, you can't lift your arm more than like 90 degrees, okay? It's very uncomfortable. Try laying down on your side with your scapula retracted. That hurts, it's uncomfortable, okay? So we want to work on that protraction. We break that tone. It's a lot more functional. They have now use of their upper extremity. They can lay down more comfortably in bed. Bed mobility tasks such as rolling, moving from supine to sit to supine. Everything is using the involved side of the body, and bridging, okay? Bridging is good because it breaks a little bit of the tone in the hips, also works on core strength, and it helps them with bed mobility. Scoop themselves, you know, so oftentimes we do some bridging exercises in the bed before we even get them up and mobilize them. All right, what questions do you have about NDT? What is our goal in NDT? To restore normal muscle tone and posture, postural control and symmetry, yeah, and normalize movement patterns, right? Okay, weight bearing, weight shifting, involving the affected side. Okay, why don't you guys take 5 minutes and then we're gonna go over and talk about PNF.